one and all. With the blessings of His Holiness, I, Dr. Chanchala, take this opportunity to greet one and all for today's program, Pediatric Dentist Alumni Meet 2020, Faculty of Dentistry, JSS Academy of Higher Education and Research. To improve is to change, to be perfect is to change often. With this thought in mind, what better can it be than Re-Envision to meet challenges in pediatric dentistry? We have with us today Dr. Norman Tinanoff, University of Maryland, Baltimore, world's first dental college, and Dr. Iraldo A. Pesarasi, San Martin de Porres University as the elite speakers for the day. We also have with us Dr. Ravindra S., Principal, JSS Dental College and Hospital, who's been encouraging in all the academic endeavors with 3 decades of teaching experience and administrative skills. We're glad to have you with us, sir. I request you to welcome the gathering.
I take this privilege to welcome our chief guest, Dr. Shobha Kuriakose, to this webinar. I also take a privilege to welcome our resource faculty of the day, Dr. Norman and Dr. Eraldo, Pediatric and Preventive Dentist, to this webinar. I congratulate and compliment Dr. Nandalal and webinar to this learning session. I thank the organizers for inviting me to this webinar. Thank you one and all. Have a great day.
Thank you very much for your constant support and encouragement, sir. Thank you once again. We have Dr. Nandalal B., who would be the moderator for today's program. Sir has been the former Dean and Principal, JSS Dental College and Hospital for 15 years from 2001. Also the founder, Head, Department of Pediatrics in 1989. Has been awarded for many outstanding achievements in the society and has innumerable contributions to research and academics. He has authored many national and international articles and books. We request you to share your thoughts and views, sir.
Yeah, thank you, Dr. Chanchala. And before we just started, I was briefing about JSS to Professor Norman and now Eraldo. As suggested, I'll be the moderator for the next 2 hours for the and I would like to thank both the speakers. It's a great to have you on board here on this platform of JSS. I welcome you on behalf of JSS Academy of Higher Education and Research. And to speak again, this periodontic 7, it's been a long way, and we thought we should meet up, and we do have alumni meets very often, but this is one of its different kind where we are meeting as a virtual. And so thanks to you both who have made it possible to join and share your views and your knowledge and experience with our alumni of our JSS. And I also like to place my special heartfelt thanks to Dr. Shobha Kuriakose and Dr. Shivakumar for joining this occasion of Pedodontic Alumni Meet, but for them, they gave the approvals and recognitions during the initial phases of our organization. Both of them I know very well from many years. We have been associated. It's more than 30 years now we know each other. And both have been the former presidents of IAPD, and I've been following them. It is great to have you both here, and I hope we have a great evening. Thank you. Thank you.
Thank you, sir. Before that, I want to wish you a very happy birthday.
Oh, no, thank you, doctor. It was a coincidence. We planned it that my students wanted to have it alumni meet on such a day that we can keep meeting in future too. Thank you. Thank you so much.
Indeed, very encouraging words, sir. It's an honor to have Dr. Norman. The story goes this way. It was a honor and request from our JSS Academy of Higher Education through Dr. Nandalal, who had an opportunity to meet personally at University of Maryland with the senior most experienced international speaker and guide to pediatric dental societies, Professor Norman Tinonoff, who accepted to join us at this alumni meet. It's a pleasure to have you, sir. Dr. Norman Tinonoff received his dental degree from the University of Maryland in 1971. After receiving his certificate and master's degree in pediatric dentistry from the University of Iowa, he spent another year at the VA hospital in Iowa City in a research fellowship. Dr. Tinonoff's 2-year military service was at the Army Institute of Dental Research at Walter Reed Army Medical Center. For 23 years, he was at the University of Connecticut Health Center, where he was director of the Pediatric Dentistry graduate program for 16 years. From 1999 to 2016, he was the chairman of the Department of Pediatric Dentistry and the Department of Health Promotion and Policy at the University of Maryland. Dr. Tinonoff has authored and co-authored over 200 publications, primarily on fluoride mechanisms, antimicrobials, caries risk factors, early childhood caries, and prevention. His current interests are concerned with preventing dental caries, oral health access for underserved children population, and developing clinical policies and guidelines for the ADA, AAPD, and the IAPD. The CV never goes ending. So just a small brief about Dr. Norman Tinonoff. I'm sure we're all eager to hear from you, Professor Dr. Tinonoff. Over to you, sir.
Thank you. Let me share my screen.
Yeah, sure. Dr. Sumo, can we do that? Yeah, we can start sharing this.
Yes, sir, we can do that. Yeah. Norman, sir, please share your screen.
Okay.
Yeah.
Okay, well, thank you all from the JSS Dental College and Hospital alumni and friends, and thank you for joining us today for this meeting. I hope you're all staying well and not producing too many dental aerosols. The topic today is the worldwide context of early childhood caries. Not only, I'm going to be talking about early childhood caries around the world. At the end of this presentation, I will take some questions. And so you can think of some questions you want to ask and write them down while we're giving the presentation. There's no need to take notes because you can request a copy of this presentation, and I'll give you instructions at the end of the presentation on how to request a copy, a PDF of this presentation. Okay.
Yeah. So yeah, we can see that.
Okay. So this is the outline of my presentation. First, I want to talk about why the term early childhood caries. It gives us a lot of insight onto what we thought about early childhood caries years ago and our current thoughts about early childhood caries. Then I want to talk about the worldwide prevalence of early childhood caries, paying specific attention to the prevalence of dental caries in India, Brazil, and the United States. Then I want to spend some time on etiologic factors of early childhood caries, and then management of early childhood caries. Yeah, I first started to get interested in early childhood caries when I read this paper by Elias Foss, the paper was published in 1962. And the title of the presentation of the paper was, "Is Bottle Feeding of Milk a Factor in Dental Caries?" in 1962. I read this paper around 1990. And one of the first things in the first paragraph, he says, "Nothing is so shocking as the examination of a child patient suffering from nursing bottle mouth." It made me interested in the topic, and that's when I started to get interested in early childhood caries. So why the term early childhood caries? It was not originally called early childhood caries. That didn't really occur until the late 90s. The first reference to early childhood caries is a paper published in 1911 called Comforter Caries. Then Elias Foss in 1962 used the term nursing bottle mouth. Then in the 1970s, there were two terms that were jointly used: baby bottle syndrome, nursing bottle caries. 1985, the term became popular, baby bottle tooth decay. 1988, important paper came out and called it nursing caries. All these titles, comforter caries, nursing bottle mouth, baby bottle syndrome, nursing bottle caries, all these are attributing the disease to the baby bottle. Okay, so in 1994, at a conference at the NIH campus in Washington, D.C., the term early childhood caries was established. And that has now superseded all the other terms. And let me explain to you why. If you look at the research, you can see that there's not a clear association between bottle use and dental caries. It's not as clear as one would think. And there's a lack of evidence that milk and infant formula are cariogenic. They may not be very cariogenic. More importantly, other etiologies such as other dietary habits, colonization with Mutans Streptococci, enamel hypoplasia need to be considered, and they are considered when you use the universal term early childhood caries. And then the previous approaches that have emphasizing the change in bottle habits have not been effective. I was part of a study that looked at changing the bottle habits on an American Indian reservation. And after 5 years of very strict treatment of changing the behavior of children that were on a bottle, the prevalence of dental caries did not change. So now the term universally accepted now is early childhood caries. So let's look at the worldwide prevalence of early childhood caries. First of all, I'm going to show you two pictures of patients that I saw that sort of broke the paradigm for me. So here's one patient that came to my office at 12 months of age, and she said that my child's teeth are chipping away. That's not really the case. This is really early childhood caries. Another patient came to me with a child, and she said my child's teeth are melting away. So both these cases are children 12 months of age, and the paradigm before that was early childhood caries really doesn't start until 18 months of age. So we now know it starts much, much earlier. So if a child looks like this at 12 months of age, the caries process must have started as soon as these teeth erupted at 7 and 8 months of age. And we all have seen the progression of early childhood caries as children get older. So here is an 18-month-old, and you can see its first permanent molar erupted at age 1 and already has a large caries lesion. So the disease process goes very, very fast in children. And here's a child at 3 years of age where unfortunately I had to extract all the teeth, upper and lower. So if nothing is treated, if there's no treatment, disease progresses. It starts in the front teeth, maxillary front teeth, and then it progresses to the posterior teeth. So this is a study that was done in Arizona in 1997. And this, although the paper's a little old now, it really gives us great insights onto the disease process and the treatment of early childhood caries. So these are 5,171 children that were examined cross-sectionally, and the ages of these children were 12 months, 2 years of age, 3 years of age, 4 years of age, and 5 years of age. And let's just look at two lines, this upper line here and these lower lines. The upper line here is caries prevalence. It's a number of children who have one or more dental caries. So for instance, a 36-month-old child, 30% of those 36-month-olds had the dental caries. And the bottom line is going to be treatment, and so we'll talk about that in a second. So you can see, like I noticed from my patient population, that the disease process doesn't start caries doesn't start at 18 months of age. It really starts well below 12 months of age. So here are children, a few percentage of children, 8 months of age, 9 months of age, are already having holes in their teeth. And so caries prevalence starts and exponentially rises at 24 months of age. It's around 15%. At age 3, about 30%. See 4, and here at 5 years of age, about 50% of children are affected with early childhood caries. And this is, if you look at this universally around the world, this is about the same prevalence that we see around the world. And I'll show you that with regard to Indian data and also Brazilian data. The bottom line here is treatment, well, partial treatment or complete treatment. And at that time, in 1997, the prevailing wisdom was that children did not have to see a dentist until age 3. And so that was prevailing wisdom, not taking into account that many kids are already suffering from early childhood caries, but this is more or less the convenience of dentists. They really didn't want to see children before age 3. So we can see very little treatment has occurred before age 3. And then you can see treatment starts at age 3 and starts going up, and a lot more treatment is happening at age 5. But here you can see this huge gap between caries prevalence and treatment, huge gap, and it increases with time. So most of these kids with early childhood caries, at least in this study in Arizona in 1997, the majority had caries, 50% had caries, and very few, at this point at 60 months of age, only 10% were really getting treatment. Huge gap between prevalence and treatment. So let's look at the data worldwide. So I've been studying and looking at the literature, trying to find where the papers on early childhood caries exist. So we can see we found 24 papers in the United States on early childhood caries, 29 papers in Brazil, 18 papers in India. And so we're going to concentrate on those 3 countries where there's a lot of data. So on this slide, you can see India data, prevalence data is in blue. US data is in yellow. So we'll concentrate on those 2. Let's first look at India, data from India. So there's only one study from India in 1-year-olds, 3 for 2-year-olds, 5 for 3 years old, and 4, and 5 studies for 5-year-olds. And the range is the entire line, and the median is the black line. So you can see in 2-year-olds in India, about the prevalence is 2-year-olds is a little bit less than 40% from 3 studies. 3-year-olds, the range is from about 10% to about 45%, with the median around 40%. 4-year-olds, you can see the range and the median. And 5-year-olds, you see the range and the median. And so the median value in India from these 5 studies is around 40%, with the range between 60% and about 30%. Let's look at the United States now. We have 5 studies in children at age 1, and you can see the range and the median, like the Arizona study, is around less than 10%. And then you can follow the median values going up and up and up. So in the United States and India, the ranges are very similar, and the median values are very similar. So worldwide, we're seeing pretty much the same thing, that the prevalence increases with age, of course, and that approximately 50% of children from these studies that I looked at, about 50% of these children had holes in their teeth at age 5. So let's look at the etiologic factors. Okay, so we want to really dig into the etiology of early childhood caries using this Venn diagram. And so we all have seen this diagram probably, that to get caries you need teeth. First you need teeth, then you need bacteria, and then you need a cariogenic diet. So let's work our way through this one by one. So with regard to teeth, there's a high prevalence of enamel hypoplasia in children living in inner cities. And if you look at this hypoplasia, you can see a lot of it is occurring on teeth that were formed prenatally, on enamel that's formed prenatally. So if you have enamel hypoplasia on these teeth that are formed prenatally on these surfaces, on these areas, this is because of prenatal hypoplasia. Something happened before the child was born, and probably in the United States, it's probably due to poor nutrition. So if you have defects on these teeth, on these surfaces, it's happened prenatally. If there are defects on the molars higher up or in the canine higher up, that probably happened postnatally. So here's a case of enamel hypoplastic areas on those primary teeth that probably occurred prenatally. These areas, because they have defects on them, are much more susceptible to caries, and it makes a child much more susceptible to caries. And this is probably due to poor prenatal nutrition. So high prevalence of enamel hypoplasia in children living in inner cities, and that probably leads to the high prevalence of early childhood caries. Now, the next factor with tooth factor, if acid level next to teeth is depressed low enough and for a sufficient amount of time, tooth mineral is lost. I think we have all seen this diagram. This was original, it's called the Stephen curve or Stefan curve. And we probably have all seen this diagram when we were in dental school. And this was really a groundbreaking paper by Robert Stefan in 1940, University of Chicago. And he really changed the concept from the chemoparasitic approach to dental caries to the bacterial acid production mechanism of dental caries. And we all know this very well, that this is plaque sitting on the teeth, and if you have one sugar exposure, it drops the pH down to the demineralization zone. We'll come back to this in a few minutes, but this is really the basic concept from 1940, and this is really was the groundbreaking change from chemoparasitic approach of dental caries to the bacterial acid production mechanism for dental caries. Okay, so the first stage of visual mineral loss is a white spot lesion. If it progresses, it continues to form a cavitated lesion. So let's take a look at this. And so we all have seen this white spot lesions around the necks of the teeth. Okay, there's no change in the child's behavior and in the preventive behaviors. We know that these white spot lesions will break down and we'll get cavitations around the necks of the teeth. So let's take a look at bacterial factors now. So the bacteria, we all know this, that bacteria attach to teeth, metabolize sugar, and form acid. Okay, Mutans Streptococci is the most cariogenic bacteria, and it's transmitted from mothers to children. So let's take a deep dive on Mutans Streptococci. So here is a system that we use to identify and quantitate the number of Mutans Streptococci. It's a very simple system where you take a tongue blade, you wet the tongue blade with the child's saliva, and you press it onto a selected media, and you incubate it for 2 days. And here you can see impressions of the tongue blade, both sides of the tongue blade, and you can see there are many, many colonies of Mutans Streptococci. And so this child has high risk for dental caries because she has so many Mutans Streptococci in her mouth. So the earlier, so adding to that, this Mutans Streptococci story, the earlier the child is colonized with carriogenic bacteria, the higher the caries risk. So Mutans Streptococci, as we all know, can be transmitted from mothers to children. So if a mother has lots of Mutans Streptococci, has high caries rates, and there's unsanitary practices between mother and child, that those bacteria from the mother can be transmitted to the child. So this is a study that was done in nursery school program, where we looked at the Mutans Streptococci levels in 10-month-old children to 15-month-old children. And we can see that the earliest we can find colonization was at 10 months of age, and it goes up and up with age. The blue is moderate levels of Mutans Streptococci, and the high is very high levels of Mutans Streptococci. So some children are colonized at 10 months of age, and then goes up with age. So the earlier the child gets colonized with Mutans Streptococci between 10 months and 13 months old, the higher their caries risk. The child is colonized maybe at 2 years of age, their risk is probably much lower. So let's look at dietary factors. There's abundant evidence from human and animal studies that sugar, especially sucrose, fosters caries. Okay, only a small increase of caries is occurred if sugar is eaten with mealtime. Okay, so it's rather safe to eat sugar with meals rather than in between meals. So caries risk is greatest if sugar is consumed at high frequency. So let's look at Stefan curve again. And so this probably explains really what's happening with caries, early childhood caries. So the Stefan curve, we saw this before, that when exposed to the sugar, the plaque pH drops to the demineralization zone. But with children, what we're seeing is very frequent eating of sugar or constant eating of sugar during the day. And so we have one sugar exposure, the pH drops, and before it rises again up to the remineralization zone, we have another sugar exposure, and then we have another sugar exposure. So the pH of the plaque adjacent to teeth stays very acidic and demineralizes teeth. So the issue here is high frequency sugar consumption. If it's just once in several hours, you have a plaque pH drop, but it will go raise up back to the remineralization zone. But with frequent sugar exposures, the pH next to the teeth stays in the demineralization zone for long periods of time, and you get acid attack. So let's explain this a little bit more. So here's a baby bottle that I found in the United States that is ideal for high frequency sugar consumption. This is made for the child to carry in their hand and walk around all day drinking from the bottle. Okay, so this is a survey that we did in Maryland to see what children drink, what do these infants drink. So the parent could respond to more than one issue, so it's more than 100% here. So they could have said milk alone and milk with sugar. But let's take a look at some of these responses. Almost 8% of the mothers said that they add sugar to milk. 64% say that children drink juice. 16% say soda. Kool-Aid, which is essentially flavored sugar water, 20%. Sweetened tea, 11%. So you can see the diets, at least in this survey in Maryland, most children are being exposed in their drinks to lots of sugar, and therefore they have high frequency sugar exposure. So I went to the grocery store and tried to find out exactly what is in these fruit juice drinks. And so we looked at, you can do this from the label. You can do this from your labels. So the one company was Juicy Juice, and they're very happy to advertise it's 100% fruit juice, but the percent sugar, if you do the arithmetic from the bottle, from the label, 13% sugar, no added sugar. Mott's apple juice, 100% juice, 100% juice. And this container says, ideal for the baby bottle. So this, unfortunately, is telling parents the wrong thing. 10% sugar. Then we have other drinks with 1% fruit juice, 13% sugar. Another one, sips, 10% fruit juice, 12% sugar. But you can see that in general, all these fruit juices and fruit drinks contain sugar, and about 12 to 13% sugar. So this sugar may be like in juicy juice, glucose or fructose, or when you, for this Squeeze-Its, where it's added sugar, it's probably high fructose corn syrup or sucrose. But all these drinks contain about average of 13%. I guess 13% is what tastes the best for children. So the American Academy of Pediatrics, because they know that very many children drink lots of juice, and they also know that that juice is non-nutritious, and it just adds extra calories, and it causes obesity and dental caries. So they came out with very strong recommendations in 2017. No juice for children under 1 year of age. 1 to 3 years of old, 1 to 3 years of age, limit to 4 ounces a day. 4 to 6 year olds, limit to 4 to 6 ounces a day. And 7 to 18, no more than 8 ounces a day. And juice should not be given in a bottle or in covered cup. So this is quite different from the normal behavior that you see, at least in the United States, where parents are giving their children lots of juice. Maybe a liter of juice a day. Sometimes we see parents come in with their children with early childhood caries, and the child walks in holding a bottle in their mouth. So here we have high frequency sugar consumption from the bottle. Okay, so the whole idea of baby bottle tooth decay really is supplanted by high frequency sugar consumption. Okay, it could be liquid, like these juices, especially juice, or it could be solid foods like candy. But it's the high frequency sugar consumption that is really the main issue that we're talking about. So caries is greatest if sugar is consumed at high frequency. So some sugars are less cariogenic than others. So let's take a look at this. So here is sucrose, which is added to some of these drinks. And you can see that the pH drop is the greatest with sucrose. But here we have fructose, maltose, and glucose. These are fruit sugars. And these also drop the pH below 5. So they're also cariogenic. Now here we have the pH drop for lactose. And you can see it's not as much. And when you actually do an experiment, the amount of acid produced by lactose is 10 times less than that of sucrose. And so it is mildly cariogenic because lactose really has to be broken down in the oral cavity by glucose to glucose and galactose by the enzyme lactase. And so that is before it can be used by bacteria. So that doesn't occur that well. And so there's not that much glucose converted from lactose. And so there's less acid production. So the whole idea that milk is cariogenic, it is cariogenic, but not nearly as much as sucrose, fructose, maltose, or glucose. Okay, so a child sleeping with a bottle with milk is much less cariogenic than a child sleeping with a bottle with fructose or sucrose or glucose. Okay, so lactose, milk sugar is much less cariogenic. So here is the American Academy of Pediatric Dentistry risk assessment tool, and for children 0 to 5. And so in this risk assessment tool, it says here, child has frequent exposure, greater than 3 times a day, of between meal sugar containing snacks or beverages. High risk for early childhood caries. Child uses a bottle or non-spill cup containing natural or added sugar frequently between meals and at bedtime. Both these things are saying the same thing. Okay, these are high risk factors. Okay, And right now, the strongest emphasis right now is on dietary control of early childhood caries. Okay, if we followed the American Academy of Pediatrics recommendations and reduced the high frequency sugar consumption, we probably wouldn't have early childhood caries. So in each environment, India, Brazil, there may be other things, other foodstuffs that are used, but still it's the sugar in these drinks, the sugar in these food products that is feeding the bacteria that's causing the acid that's demineralizing the teeth. So that brings us to management. So we want to break down management into three things: primary prevention, prevention of caries before the disease is evident. This is really the area that we all need to be working on, primary prevention. So secondary prevention is control of initial lesions prior to cavitation. This is a child who has white spot lesions, but they have not cavitated yet. That's secondary prevention. Tertiary prevention is arrest of cavitated caries lesions, community appropriate caries control procedures, tooth preserving restorative care. So let's go through these one by one. So primary prevention, that is involved in, for the individual, identifying early childhood caries risk factors. So you want to do a caries risk assessment in these children at age 1 or even earlier to find out, do they have risk factors for early childhood caries? So clinical examination and determine care paths for that child. So part of primary prevention is to talk to the parents about limiting sugar intake in food and drinks and actually avoiding sugar for children under age 2. The WHO recommendation now is avoid sugar for children under age 2. Second important preventive guidance here is to perform twice daily brushing with fluoridated toothpaste. The recommendation is 1,000 parts per million using age-appropriate amount of paste. So let's show you that for a second. So first of all, let's look at the examination. And so for these young children, age 1 children, we're doing what we call a knee-to-knee examination. Excuse me. So this is the child is being held by the mother with it up to her chest, and the child's legs are on either side of her. And then when the dentist is ready, she drops the child down to the dentist's lap, and her knees are touching the knees of the dentist. So that's what we call the knee-to-knee position. So the dentist at this way really has a great view of the mouth, and I'm sure we all do this, and you know that the child is often crying. So you have a great view of the mouth, can get a great examination. So let's look at now the preventive guidance approaches. So we talked about toothbrushing with fluoridated toothpaste. And so we don't, children under age 6 swallow, mostly swallow the toothpaste. So we want to control the amount of toothpaste that's on the brush. That controls the amount of fluoride that goes in the mouth and the amount of fluoride that's swallowed. So the recommendation now is a smear or a right size amount of fluoride of toothpaste for children under age 3 years of age. So here we have about 1/10 of a gram of toothpaste on the brush on an infant's toothbrush. And this should be started as soon as the teeth erupt in the mouth. For ages 3 to 5, the recommendation is a pea-sized amount of fluoride in the tooth, of fluoride toothpaste on the brush. And of course, the parents are brushing the child's teeth, not the child. So this is a friend of mine, pediatric dentist, and her child was very resistant to getting their teeth brushed. So she wrapped him up with her legs and she brushed his and showed him that she was going to brush his teeth no matter what. And after a week of doing it this way, the child said, "Okay, I give up. Just brush my teeth. You don't have to wrap me up." Didn't actually say that, but became very, very compliant. So I really get upset, and when I hear a mother say, my child will not let me brush his teeth. So secretly, I mumble under my breath. I'm mumbling, who is really in control here? Are you in control, or is your infant in control? Okay, so you just has to be persistence. If the child is resistant, and in a week or so, that resistance is going to disappear. And we even know that I have friends that brush their dog's teeth, and it's the same thing. It takes a little while for the dog to get used to getting his teeth brushed, but after a while, he gets used to it. So the same applies for children. Let's talk about secondary prevention. This is when we have white spot lesions and we want to stop them from getting any worse. And so the term now has started active surveillance, where we are going to watch these lesions, but actively watch them. That means that we're going to apply fluoride. We're going to have the parents brush the child's teeth twice a day and try to arrest these lesions. So here we have white spot lesions here that we are going to do active surveillance on if the parent is cooperative, and also if we are sure that we're going to see this child on a regular basis. Here we have enamel etching on distal surface of the first primary molar. Again, we're going to try active surveillance to arrest these lesions. A lot of lesions arrest over a period of time, especially when the parents are actively engaged in toothbrushing and actively engaged in changing the dietary habits. So active surveillance is the term that we're using now of initial lesions. We're not treating them right away. The old way was to treat these lesions by doing a filling or a crown on the teeth, but now the idea now is active surveillance. It depends on the active prevention by the parents and oral health provider, and active and regular recall visits. If these lesions progress, then we have to restore them. We have to go to tertiary prevention. But really our goal here in secondary prevention is active surveillance and giving time, maybe initiating active surveillance, re-examining in 3 months or 6 months. If the lesions grow, you have to restore them. If they don't, you have a great success. And for me, arresting these lesions here and child not getting any further cavities is the greatest thrill in my life. It's my greatest success when that happens. I am so happy to show these pictures of my successes. So other tertiary prevention we're talking about is arresting cavitated lesions. And here we're doing that with silver diamine fluoride, where you already have cavitations and you're arresting these lesions with silver diamine fluoride. And this improves the arrest rate greatly, from about 30 to 40% that we can do with active surveillance to about 90%. The other community approach, which is started in Thailand and also now also started in India, was a community appropriate caries control procedure. And this is glass ionomer restorations, either in worldwide called ART, in the United States it's called interim therapeutic restorations, but with the increased strength of glass ionomer, these newer glass ionomers, these single surface, when they're single surface cavities, hold up just as well as a single surface composite restoration, okay? So not so much if it becomes a two surface restoration or MO or DO, or in this case OL, doesn't hold up as well. But we see a great value to this, especially in areas, rural areas where you don't have electricity, you don't have running water. And this is a great advance in tertiary prevention. And of course, we often have to do tooth-preserving restorative procedures, class 1 composites, stainless steel crowns. So tertiary prevention. The thing that we do, but hopefully we are able to do primary and secondary prevention and tertiary prevention when necessary. This is the International Association of Pediatric Dentistry Care Pathway for Early Childhood Caries, published in 2020, just published. So let's look at low-risk children and high-risk children. So we're looking at caries risk indicators. You don't have to write this down because you can, I'll send you my slides. And diagnostic procedures for a low risk, so a child that's identified at low risk. Exam interval probably at 12 months, every 12 months. Radiographs 12 to 24 months. And brushing with fluoridated toothpaste twice daily, and sealants even on the occlusal surface of primary teeth. Okay, so that is a recommendation. And if it's a child that's low risk, they need less care. And let's compare that to a high-risk child. So high-risk child, instead of exam every 12 months, we want to see this child every 3 months. Radiograph interval probably every 6 months, and then probably need to do a diagnosis. We need to find out why this child is at high caries risk. And the universal recommendation for all children is brush with fluoridated toothpaste twice daily. Now, if they live in a non-fluoridated area, you may want to think about systemic or dietary fluoride supplements. We want to do professional topical fluoride treatments every 3 months, sealants. And for children over age 6, high potency fluoride gel. This is 5,000 parts per million toothpaste instead of 1,000 parts per million toothpaste. This is very effective in also arresting caries progression. So in these cases, we still want to think about active surveillance, but active surveillance is probably going to work better here in the moderate risk child who actually, because of good preventive behavior, becomes a low risk child. But still, I think about active surveillance for white spot lesions. So if we see a white spot lesion, I don't do anything with it. I try to arrest it. But restoration of enamel proximal lesions and restoration or silver diamond fluoride for progressing lesions. So if a child is at high caries risk and has an interproximal lesion, I'm going to restore it, as opposed to in a moderate risk, and it's still going to be active surveillance. Okay, so also any cavitated lesion, of course, we need to restore form and function to the tooth. Another thing that we want to think about is advocacy for early childhood caries. So this is primary prevention, upstream primary prevention, where we really want to stop the disease as a public health measure. So we want to raise awareness of early childhood caries to parents and caregivers. So when they're counseled, that they understand what early childhood caries is and how to prevent it. We want to get other health professionals and stakeholders involved in it. So community health workers, and I think community health workers are very popular in India to spread the message about early childhood caries and how to prevent it, how to arrest the progression of early childhood caries. So I know you have very strong community health worker programs in India. So, as well as other stakeholders, and this is legislators that we want to tell legislators about the big problems with early childhood caries and how the government can help. Then we want to advocate for sugar reduction strategies, not only telling parents about this, but like in Mexico and some places in the United States, where they've instituted sugar taxes, additional tax on foods that are high in sugar, or drinks that are high in sugar to reduce the usage of these drinks. And these have been very effective in reducing the amount of sugar that is bought in stores. So sugar taxes. So we also want to advocate for increased government insurance and funding for preventive procedures. So what we've done in Maryland is that there was a very good charge for pulpotomy and crown procedures from our government insurance programs, but little reimbursement for toothbrushing instruction on how to reduce early childhood caries. So what we did in Maryland is we increased the funding for preventive procedures and reduced the funding for pulpotomies and crowns to help dentists do the preventive procedures in their office. So changing the paradigm from restorative dentistry to preventive dentistry. Okay, and also advocate for not only dentists providing the care, but as we mentioned before, other health professionals, physicians, community health workers, especially in the first year of life. Because still, in the United States, and I'm probably also in India, in the first year of life, children are not seeing a dentist. So we want the community health workers and the physicians to do the work that is not happening with us because parents still aren't bringing their children to a dentist in the first year of life. So there's two papers that just came out from the International Association of Pediatric Dentistry. It's called the IAPD Bangkok Declaration. That's published in International Journal of Pediatric Dentistry in 2019. And another paper called Early Childhood Caries Epidemiology, Etiology, Risk Assessment, Societal Burden and Management, Education and Policy, IADR Global Perspective, also in the International Journal of Pediatric Dentistry 2019. So perhaps everything I said, you can find in these two papers. And so these are really good resources, and take a look at them because I think they're up-to-date papers, and they were done in Bangkok, and we chose Bangkok because we knew that Bangkok represents the dental health situation in many countries in the world, probably very similar to India. So take a look at these papers if you get a chance. I think they are very helpful. And then also, here's my email address, antininoff@umaryland.edu. If you want, you can write this down, and then you also can email me. If you want the slide presentation, I'll be very happy to give it to you. So antininoff@umaryland.edu. Okay, so now I'm open to getting questions or comments from the audience. So please submit your questions or raise your hand, whatever, however we get the questions, and we'll be happy to have a discussion with everybody.
Yeah, thank you, Professor Norman. It was, I would say, before I would open the questions, which I can see some of them have put forward. It was a very interesting slide where you showed the global concept, particularly when US and Indian study, in a very simple single slide to get the concept of the changing patterns in early childhood, because many a times all these epidemiology studies we have been focusing on 12, including the WHO, like 6 years, 12 years, and other index ages of 35 and 65 and all that. This single slide, which gives us a clear picture, for particularly for the people who are looking forward in a quick way, it was a very simple slide which could give a lot of meaning. I'm sure many who are listening, yeah, it was wonderful. And to compare India and USA, that we are, though we have the range similar, and many people, and the stress you have given that we have to see the median, which is more important, though the range may sometimes be touching on two other extreme ends.
Yeah.
Is a very important point. Many of us should be taking forward and look at the data very carefully. One good thing about this is we are very happy. That means there is a lot of calibration of Caries recording system, which these studies have come very close to each other. That shows that we can do some joint comparative studies in the years to go.
Yeah. Well, the interesting thing to me is that early childhood caries is a global issue, and the prevention is really the same around the world. It's primary prevention and secondary prevention. When we get to tertiary prevention, that's where things deviate. Okay, and then we can be very fancy with our tertiary prevention, stainless steel crowns, space maintainers, but we don't want to be there. We want to be in primary prevention, secondary prevention, and globally, that can be accomplished. Tertiary prevention probably doesn't work for every country in the world, but primary prevention and secondary prevention is really the message globally.
Yeah, and the message of particularly the dietary exposure to almost the recommendation is zero sugar.
Zero sugar for the first 2 years of life.
First year life. It's a very important message required for many Asian countries, particularly because they feel the babies are underfed and they would like to overfeed them. So I think there is new change in the, I won't say new change, but a cautious stressing factor is a real need today to look at whether, because the hygiene is related to the diet. And if we can take care of the diet, obviously the hygiene would be taken care as well. So I think this.
Let me explain something here. There was a study in the United States that looked at children that consumed lots of juice versus children that consumed little juice. And the children that consumed lots of juice were fatter and smaller, and their height was smaller. So they are really, you are undernourishing a child by giving them juice because it's empty calories. It's not useful for their growth. And so they're filling themselves up with sugar, and they're no longer hungry, and so they're no longer eating the correct foods. And so you're really undernourishing a child rather than overnourishing a child when you give them large quantities of juice.
That's what quite informative about the types of juices and the composition, how it affects. I'm sure now most of the countries will seriously look and do research on this pre-processed or food or juices which are available, and the sugar levels. In fact, we had done some couple of studies in India as well on the packed juices which are available. It's very alarming to see the pH level when we have compared the fresh fruits and fresh juices and compared to those which are preserved and sold. It is very annoying, but I think there has a Food Regulation Act has to play some role there to see how best the safe for teeth is provided, and note particularly for the children who are very young, and it should be a part and parcel of the policies in the years to go. Now,
go ahead.
Yeah. Thank you for this valuable information. So I will open up a question here. What should be the time interval for the patients visiting during the active surveillance in the secondary prevention?
Yeah, so with active surveillance, I really insist on recalls every 6 months.
Yeah.
It takes 6 months to see if there's a lack of change or change. So it's important for active surveillance to assure that you're going to see that child every 6 months. So that's what I do. But when I'm doing active surveillance, I often want to see the child on a 3-month interval just for fluoride treatment, just for professional fluoride treatment, and being assured that the mother is brushing the child's teeth regularly, twice a day with fluoridated toothpaste. So for me, I like to see the child for a quick visit every 3 months, but every 6 months I want to get an examination and I want to get new bite lengths, especially if there are hints of interproximal caries.
Okay. There was a general, one more question was about the brushing. Are you specific about using a toothbrush or a finger brush? Would it be a possibility of a preference or?
Yeah, I personally like using an infant toothbrush. I just think it's easier for me. But it's more important rather than what type of toothbrush is, that you're giving the right amount of fluoride, putting the right amount of fluoride on the brush, however, whatever brush you're using, for those infants, a smear or a piece size amount or right size amount, and you're brushing the teeth twice a day. So it's more, for me, the brush is a delivery system for the fluoride. Not so much, I'm not that worried about brushing the teeth and getting all the plaque off the teeth. There's not going to be much plaque anyway, but it's a delivery system for the fluoride.
Okay. I think there was one more question is, there was an option about the tertiary treatment, that is whether to give STF or a restorative care. So how do we decide that? Is it because of the cooperation of the child, or is it because if the lesion is very deep?
For me, it's informed consent. I ask the parents what they want to do. First of all, if you use SDF, the teeth are going to turn black. And so the parents have to be aware of that and give consent to that. Some parents say, no, I don't want my child's teeth to be black. And so then the option is restorative dentistry, is traditional restorative dentistry. So for me, it's informed consent, and that drives my treatment plan. I would certainly, and it's easier to apply SDF, especially on front teeth, and it works well. SDF doesn't work that well as well on the posterior teeth, because if you have interproximal cavities in the posterior teeth, food getting trapped into those interproximal areas, and caries progresses more so than in the front teeth. So SDF is working better in the front teeth than the posterior teeth. So in the posterior teeth, I'm not relying on SDF as much. I'm doing more restorative dentistry. But again, if I'm doing SDF on the front teeth, it's informed consent with the parent.
Thank you, Dr. Norman. I think we have taken questions, but there is one last question. We can take it if it's okay with you, because
Yeah, sure.
Two siblings having same oral hygiene habits, dietary exposure and fluoride exposure, still one of the sibling has ECC. What could be the reason? Is it the structure of the tooth? If so, how to deal with such cases of primary prevention?
Yeah, so that's always been a mystery to me, but really there's a genetic component. There's certainly a genetic component, and one kid may take after the mother, one kid may take after the father. So we don't know exactly how much the genetic component is, but it's certainly there. It's certainly there. And the whole idea of, quote, soft teeth, it does exist. But we can't do anything about that. We can't do anything about that. The only thing we can do something about is prevention, okay? And so that child who is at higher risk because of genetics, the prevention is more important for that child.
This is whether there is a possibility of looking at a particular toothpaste based on the water fluoride level. Should it be considered?
Not really, because so if I don't know exactly what your situation is in India with regard to water fluoridation. So in the United States, a lot of the water systems that are supplying, community water systems are applying 0.7 part per million fluoride. And so the idea is, and that's a systemic approach. It's a dietary approach. And that is very effective. It's about 30% reduction in caries due to fluoridated water. Toothbrushing, these young children will swallow some of this fluoride, but that is why we want to carefully regulate how much is on the brush. The smear for very young children, pea size for older children. Even if they swallow the whole thing, it's still safe. it's still safe even though the water is fluoridated. So, and it's additive. The prevention is additive to that fluoridated water.
Okay. Thank you, Dr. Norman. I think we have Professor Norman has to go for another session, and we are very happy that the session went on well, and I'm sure there are many more questions which I will definitely pass on to Norman. He would definitely respond, I'm sure, with all the answers and to see what we can do in future programs.
If there's any further questions, feel free to use my email, contact me. I will be happy to answer and also be happy to share these slides with you.
Yeah. I thank on behalf of the JSS Academy of Higher Education and Research, and I wish to share the greetings from the Vice Chancellor of JSS Academy, who is going to join us a little later at 6 o'clock session. He conveys his special greetings and thank you, and particularly the University of Maryland, Baltimore, for making it possible that you could give your time to our organization. Thank you, Dr. Norman.
It was my pleasure. Thank you.
Thank you.
Dr. Iraldo A. Pisarasi, dentist, graduated in the Federico Varela University in 2009, completed his master's in dentistry in the San Martin de Porres University, Lima, Peru in the year 2015, PhD in medical science, oral global health in the Radboud University, Nijmegen, the Netherlands, 2019, member of the International Association for Dental Research, junior faculty of the Dental School of the San Martin de Porres University, Lima, Peru. Over to you, Dr. Iraldo A. Pisarasi.
Good evening, and thank you for the kind introduction.
Pleasure is ours.
Good evening.
Please let me know if my screen is properly shared.
Yes, it is visible.
Fantastic. Well, thank you so much for your kind presentation. Thank you, Dr. Nadal, for your invitation for this meeting. It is for me an enormous privilege to present this lecture, especially being after Dr. Tinanov, that is quite a referent in terms of early childhood caries. So I have to be very prepared to satisfy your standards now.
Oh, you're welcome.
So this evening I will share with you something that has been a matter of my clinical interest during the last couple of years, that is chemico-mechanical caries tissue removal for caries lesions. Just share a little bit about me. I am a Peruvian dentist. I have been trained in the Federico Villarreal University. Then I started my master's in the university that I work currently, the San Martin University. And during these years, I have been the privileged to work with Dr. Rita Villena and Dr. Joe Franken, who was my supervisor during my PhD studies, and recently defended my thesis last December. So I am quite happy of completing this fantastic goal. The outline of today's lecture will be modern management of dental caries through minimal intervention dentistry. I will do some of the evolution trends in terms of chemico-mechanical methods, talking about the strategies that work with primary and permanent teeth, using glass ionomer cement as a restorative material, using composite resin as a restorative materials, and also looking at chemico-mechanical strategies as a non-aerosol producing alternatives now in the post-COVID dental practice. So to start with, and following the comments from Dr. Tinanov, we should recognize that dental caries is still a global health issue. In this publication from 2013, it has been stated that untreated dental caries is still one of the most prevalent conditions in mankind, being in the first position for permanent dentition and in the 10th position for the primary teeth. Something more concerning is the global trends that we see in this more recent publication about the trends of the dental caries in the primary dentition in the blue line, you will see how from the first day of life, you see a line that goes up and up to the 4th year, following the same trends that Dr. Tinanov shared with us about dental caries showing the signs and symptoms even before the 1st year of life. So that's something that is really concerning to our profession. The same kind of trend was presented in this meta-regression analysis as a very complex strategy to measure different epidemiological studies where we see 3 particular peaks around the life of the individual. First, at the age of 6, then age of 25, and lastly, at the age of 70. This is particularly related with diet, the saliva capacity, and of course, the self-capacity we have to take care of our own dentition. But something alarming that we will see in both prevalence and incident rates will be this very, very pronounced growth in dental caries from the first 6 years of life. It's like from the year 0 to the year 6, we see a very, very dramatic growth in the prevalence rate of caries. And this, of course, is not only limited to the oral health, but also brings some terrible consequences on the quality of life of the individual. These young children, this is a particular case from one of our studies, a 3-year-old kid who has this terrible destruction of his teeth due to the consequence of an unhealthy diet, bad hygiene, non-visiting the dentist, and other factors. So this is a very concerning issue in our country. A global response to this concerning problem was this meeting of experts to promote a public health intervention against early childhood caries. They recognize that caries can start very early in life, having these high prevalences around the globe. And the global epidemiology, as Dr. Tinanov showed, is quite similar in terms of appearing very early in life, particularly in minorities, social minorities, or deprived areas of every country. So we are sharing this common issue around the globe. The patterns are also similar in terms of the appearance of the disease during the first 2 years of life, developing rapidly depending on the diet and affecting the quality of life of the individual. Basically, we are talking about socioeconomical issues, behavioral components, and microbiological factors, as Dr. Tinanov stated. And a response to this global problem was the presentation of this concept as an holistic approach to prevent and treat the disease, dental caries, that was called minimal intervention dentistry. The first paper that was a matter of an agreement came up in 2012, and then it was part of the Poznan Declaration from the International Federation of Dentistry, the FDI, or the World Dental Federation. These principles have these 5 components. First, an early diagnosis of the disease, starting with this important concept of caries risk, as Dr. Tinanov mentioned as well. We have to measure the risk as the main element of our diagnosis, not only the signs and symptoms of the disease, but going back to the start, or the real reasons why these kids are sick of dental caries. The second component will be remineralization of dentine and enamel lesions to arrest the progression of the disease. Prevention, primary, secondary, and tertiary prevention to stop the caries progression. And if these 3 first strategies fail, or if we see this child too late, we will have to implement minimally invasive restorative care and repair and polish those restorations that maybe are failing or fractured. Something important to recognize around this concept is that minimally intervention dentistry is not a synonym of minimally invasive dentistry. Minimally intervention dentistry is a holistic approach of the disease dental caries, and minimally invasive dentistry is related to an operative process per se. That means preparing or preserving the most healthy tooth structure as possible, or using laser or chemical-mechanical methods or a traumatic restorative treatment as an operative procedure. So within these definitions, what are the challenges that we have to confront as a dental profession? First of all, we have to recognize that there is a problem on the understanding of dental caries. During decades, dentistry has considered dental caries as an infectious or infecto-contagious disease, which require the elimination of all the etiological bacteria that we have in a cavity. However, if we analyze the most recent studies about microbial contamination of early lesions, we might see that in this kind of early lesions, white spot lesions, we already seen a penetration of bacteria in the enamel, in intact enamel in the clinical examination. Additionally, when we see this kind of cavity preparation, when we reach this hard denting, this is not a guarantee that we will eliminate all the bacteria. There are studies that have recognized that even reaching this hard denting in a very invasive cavity preparation, we will still have bacteria. So no operative process will guarantee that we will eliminate all the bacteria from the dental structure that have suffered from a dental caries lesion. So we have to remove that idea from our mindset. In the recent years, there has been consensus about the terminology and management of dental caries. One of them was published during the first months of this year, issued by the European Research Cariology Group, ORCA, stating this important definition of dental caries that is in line with the one published by the ICCC in 2016. Dental caries should be considered a dynamic, biofilm-mediated, diet-modulated, multifactorial, non-communicable disease resulting in a mineral loss of the dental hair tissues, and it's determined by biological, behavioral, psychological, and environmental factors. Something really important is the sentence that we see in pink color, because we have to recognize that dental caries is not an infectious disease, but a biofilm-mediated, diet-modulated. Basically, we're talking about sugars. Something important to differentiate as well is that it's not the same talking about the disease, dental caries, than talking about the dental caries lesion. It's like talking of a diabetic patient and talking about improper microcirculation as a consequence of the disease. So the disease is actually a multifactorial component, and the lesion is what we see clinically. Therefore, treating a cavity with a restoration is not treating the disease. It's only reversing the symptoms and signs that we see as a consequence of the disease. Basically, nowadays, the most accepted theory about the caries etiology is the one proposed by Philip March in 1994, that states that the start of this disbalance is the increase in the sugary drinks and snacks. As Dr. Tinamov has stated, the common risk approach that was proposed some years ago is basically oriented to reduce the consumption of sugars, or at least try to do it in a less risky frequency. This high frequency of sugars will alterate the ecological shift, but will produce an ecological shift in the bacteria that we have in our mouths, and will promote production of acids that will end up demineralizing the tooth structure and generating what we call the dental caries disease. Something that we have to recognize, as Dr. Tinanov also mentioned, is that not all sugars are the same. If we follow the results of this study from our colleagues from Unicamp in Piracicaba, they mentioned that the profiling of the pH curve in the Stefan curve after eating glucose and fructose from a fruit, for example, generates this particular curve that recovers very rapidly the physiological pH in the saliva. It does not take too long for the saliva to buffer those acids. However, when we compare it with a highly sugary snack, the saccharose present in those foods will drop the pH, and it will take longer for the saliva to recover that physiological pH. And not only for the pH profiling, but also for the consequence that these sugars generate in the biofilm. These sugars will organize differently the biofilm structure, because as a consequence of the free sugars available there, the bacteria will produce unsaturated polysaccharides. These will be like a scaffold in which other bacteria will be added up and will create a more resistant biofilm. It's going to be more difficult to remove, and they have a more structured way of communicating and transporting sugars to the inside of the biofilm and acids to the tooth surface. And that's why it's so important to regulate sugars as a main goal of the dental caries treatment. Especially in the frequency, something important we have to take into account is something related to the diet counseling. We have to analyze what are the food patterns around the day, because saliva will take from 40 minutes to 2 hours to recover that physiological pH after one meal. But what happens if we have several meals or several snacks a day? We will have constant drops in the pH, and the saliva will not be able to recover those mineral loss. And that's why this is going to be the point of, or the starting point of the development of a dental caries lesion. So the frequency is more important than the amount. It's not the same to eat an entire bag of candy in one single moment a day and then brush your teeth and keep drinking water the rest of the day, then you using that same bag of candy and eating one and then 10 minutes before eating another one, and so on during the day, that will maintain the pH very low, weakening the tooth structure. Some studies has claimed that 5 moments of drops a day will be like the difference between a low or a moderate or a high risk patient in terms of the diet profile. Some more complex analysis by an expert group from the group of Dr. Carlos Feldens have studied the frequency of sugar consumption, showing clearly that those groups that have higher frequency of sugar consumption, even if it's breast milk, bottle use, or other foods and snacks, will generate a higher risk of development of dental caries very early in life, at the age of 12 months. So the arch enemy of dental caries should be always sugar. Sugar intake, not only but because of the development of dental caries, but also because it's a risk factor for other non-communicable diseases such as diabetes, obesity, kidney failure, and even some types of cancer. Another challenge for the clinician is the detection. We have to be trained in detection methods similar to the ICSI does, for instance, that will give us a trained decision-making in terms of every stage in the whole spectrum of the disease progression. We should be moving away from that classic definition of the DMFT that only consider cavitated lesion as something that should be epidemiologically concerning. And together with it, we have to evaluate the activity of the lesion. Because dental caries is a dynamic process, we should also incorporate the concept of the activity in terms of recognizing which of these lesions will progress if we do not intervene, and which will be more prone to maintain stable. Some aspects about the recognition of this activity will be a visual inspection with a yellowish or a light brownish aspect of the dentine, and sometimes it goes together with a white halo around the enamel limits. If you are not sure, you can use a tactile method using maybe a round tip probe to recognize if this dentine is soft on touch. When we have an inactive dentine lesion, we will see it a little darker and shiny. When we want to confirm this finding, we could use a sharp element to touch the surface and be able to recognize if we are dealing with an inactive dentine carious lesion. Now, the big question is how to intervene in the carious process. We have been discussing about restricting sugars, but there are also strategies for biofilm control to restore the mineral balance, and that's not enough. We have to use more invasive methods, because something important we have to highlight is that restoring without changing habits is like changing a window in a building on fire. It's nothing. It will be no use just to restore. What are the consequences of the disease if we don't treat the etiological factors? We don't evaluate diet, if we don't evaluate the hygiene, frequency and quality, we will be unable to keep this child healthy in the future years. So one proposal to manage this tertiary prevention concept is the cleaning of the cavitated lesions. And I underline the cleaning word because it's not a cavity preparation what we are going to do. Cavity preparation is a concept that goes back to the age of plaque, where we have to prepare walls and boxes and physical retention, because in that time they don't have adhesive materials. They use gold foil or amalgam to restore carious teeth. But today with adhesive materials, we have to be more conservative in terms of only removing that tissue that is completely decomposed. This concept appeared during the 70s from the group of Fusayama, when they detect the two layers of the carious dentin, an outer layer that was composed of completely decomposed dentin that was full with bacteria, was incapable of remineralize, and was necrotic. However, there was a deeper carious lesion or carious dentin that has mildly disorganized collagen fibers, and it was a viral dentine and has a potential to remineralize. Therefore, it should be preserved. Something that mislead the dental profession was these terms that were used by Masler in the 60s, that was the infected and affected dentin, that many dentists have adopted and keep saying infected and affected to our days. However, we should take the previous classification or the now accepted terminologies in the recent publications. So once we are dealing with a cavitated dentine lesion, we should choose one minimally invasive technique to intervene. Among the consensus that was produced by this Delphi publication, we have selective carious tissue removal, the atraumatic restorative treatment, the stepwise excavation, and also combined strategies or ultra-conservative strategies such as the non-restorative approach, the Hall technique, and the silver diamine fluoride. Now, when we talk about selective carious tissue removal, the recent consensus have stated that the total removal that Black proposed 100 years ago is no longer recommended. So we have to be selectively removing whatever is decomposed, something that is the outer layer of the dentine, it has a very high concentration of bacteria, it's a necrotic dentin, it's not useful for adhesive procedures, and that doesn't have the capacity to remineralize. However, underneath this outer layer, or the previously called infected dentin, we have a demineralized or a deeper carious dentine that is, of course, deeper than the previous one, has bacteria, but in a lower proportion, is a viral dentine, and it has a remineralization capacity because the dental tubules and the odontoblast tails are leaving some crystals as a defense mechanisms, and this has the capacity to remineralize in the future, always if we provide a proper sealing around our restorative material. And this is a way to preserve the sound and the dentine structure that has the potential to remineralize. The main question that you should ask ourselves before restoring any cavity is, why do we do it? Sometimes we respond to this question about aesthetics or function or restore the shape, but actually the main reason why we should restore a dentine cavity lesion is because it's difficult to control the biofilm when we have a cavity. Therefore, our main goal of restoring is to help the patient to remove better those biofilms or those food remains from those cavities. A second objective will be to protect the dentine pulp complex with a good seal restoration, and last but not least, to restore function, anatomy, and aesthetics. Based on this international consensus about terminology and the recommendation on carious tissue removal, they present this diagram in which we have different options for shallow or deep cavitated dentine lesions. And it is actually going back to the concepts of the group of Fusayama, actually based on this diagram that we adapted to give a better understanding about how is the behavior on the structural affected dentine. If we see on the right side, we see the superficial area of the dentine lesion where bacteria are present, is a decomposed dentine. We don't have sensitivity because it's a dead tissue. And of course, underneath that, we have minimally invaded by bacteria with remineralization potential, is a sensitive dentine, and it's a live tissue. Therefore, when we reach this area with a hand excavator or another instrument, the patient will feel or will complain about sensitivity. So the great challenge for the clinician is, how can we recognize when did I reach this transparent zone of the dentine in order to preserve the dentine with remineralization potential. That attempt was answered by the production of this product, that is the Caries detector, that was like a fuchsin-based product initially, that then was restored by a more complex chemical structure to detect the mineral content lost of dentine together with organic material and acid produced by the bacteria. But actually, the recent studies have shown that the Caries detector actually also stains the organic matrix of the mineralized dentin, but also the enamel dentine junction of healthy teeth. So it gives us false positives. Therefore, it will force you to remove more tissue than necessary when you use it without proper judgment. Another response to that complaint or to that limitation of the Caries detector was this guide that tries to give you a clinical parameter to an histological finding. If we compare what is a necrotic dentin or a contaminated zone, we have clinically a soft dentin. When we have a demineralized tissue, we have a leathery or a firm dentin. And when we reach the sound dentin in the bottom of this lesion, we will reach a hard dentin. And that's why we could identify the different layers by clinical findings, basically on tactile manifestations. Just to give you an example of how you will perceive the different dentines, this is an example or a practical example of soft dentine. It's a dentine that will deform easily with a sharp instrument or a probe. It's very wet and it will be easily removed with a hand instrument. The leathery dentine is this dentine that will not deform so easily with the instrument, but could be lifted without any force. You will see leathery structures or like little foils that will be removed if you put little pressure on the hand instrument. And underneath it, you will find the firm dentine. This is a physically resistant dentine to hand excavation, and some pressure need to be executed in order to remove the dentine structure. In this particular area, we could stop our instrumentation in the pulpal wall, for giving you an example of selective caries tissue removal. But when we reach the hard dentine, you will see that we will need a very high force to remove the dentine, and we'll be giving this credentinaire sound. It's very scratchy and it will demand a lot of force. This dentine is only required to be reached in the margins of the cavity. If we are preparing a class 1, for example, this is something that we only reach in the enamel dentine junction around the cavity, and in the cavity floor, we will be selectively removing depending on how deep it is. This selective caries tissue removal is actually something that will prevent a pulp exposure. A pulp exposure actually is quite high or has a very high risk in primary teeth because of the proximity, especially with the proximal walls. And when we talk about direct capping, this is something that will not have good prognosis. So instead of reaching hard dentine to make sure that you are getting rid of every bit of bacteria, it's better to leave soft dentine in the pulp wall than trying to get to hard dentine and run the risk of exposing the pulp. This also, of course, goes together with a very good diagnosis of the pulp vitality, trying to do some vital tests, do an X-ray to know if there's any signs of irreversible pulpitis. And if not, if we have only reversible pulpitis or only sensitivity due to exposed dentine, we could proceed with the selective caries tissue removal. This kind of approach will guarantee that will favor pulp vitality and a long-term survival of the teeth, especially doing a more simpler procedure, saving this patient for going through an endodontic treatment, a more complex restorative care, and more expensive costs for them. Now, knowing that we have to choose a selective method, which one will be best for us, or which one will be more conservative? Many studies have been conducted around the concept of selective caries tissue removal using different tools. One of them is this smart burr made of a polymer that is selective because it will destroy itself when reaching hard dentine. Of course, it has some limitations. The main one is the expensive device that it is. It costs like $20 and it's only single use, so it's quite self-limiting for other economies. Another strategy is to use a hand excavator that is quite useful if you are properly trained, and it has to be a sharp instrument it used alone. And finally, we have the carbide burr that is quite effective as well to remove decomposed dentin, but is also a matter of proper training. The carbide burr should be also selectively used to go around the peripheral walls of the cavity and try to leave the soft dentine in the base of the cavity in case we have a deep lesion close to the pulp. Recent studies comparing the polymer burr versus the selective carious tissue removal with a hand excavator have shown no differences in terms of survival of the restoration and any side effects of this selective carious tissue removal. Therefore, we will prone to be inclined to use a hand excavator that is more applicable and less expensive. Some studies that from the University of Leuven, where they study a lot of addition principles, have been orientated to analyze which of the strategies of carious tissue removal will be more effective using microtomographies as a standard of the investigation. And they have claimed that from all these 9 strategies to carious tissue removal, the ones that are more close to the ideal are the mechanical removal with hand excavator made of plastic or hand excavator made out of metal or blunt instruments. Another alternative is the carbide burr, but also always reaches only the periphery of the cavity and trying to not to get to hard dentine in the base of these class 1s. So we have the best strategies for carious tissue removal will be a combination between chemical-mechanical, mechanical removal, or carbide burrs. So the topic that gathered us today is the chemical-mechanical carious tissue removal methods. It is a combined strategy. It's a chemical agent that goes together with a hand instrument, a hand excavator, that doesn't need to be blunt, doesn't need to be sharp like the traditional hand excavation, but could be used in a blunt instrument just to differentiate which one is the decomposed dentin that should be removed and which dentine is the demineralized that should be preserved. These chemical agents actually belong to 2 groups, one of sodium hypochlorite and the other from papain, an enzyme. Degrade the partially decomposed dentine and gives you a more sensitive way to differentiate one from the other. The historical development started back in the 80s with the Caridex. That was the first commercially available carious tissue removal from the chemico-mechanical strategies. Due to the complexity of the system and because it was very expensive and uncomfortable for the patient and time-consuming, it was removed from the market. And in the 1998, a Sweden product called Carisolve was launched, taking into account all the disadvantages that the Caridex had. This becoming a more simpler tool, then was improved in 2004 with a new presentation with a multi-mix syringe in an auto-mix tip that will be applied directly to the cavity and will take about 8 to 10 minutes to remove selectively the decomposed dentine. In a parallel story, in Brazil in 2003, it was developed this product that was called Papacari. In Portuguese, it's Caries eater. So it's basically an enzyme based on papain gel that uses some, the function of the papain is to denaturalize the collagen fibers, breaking the hydrogen bridges, and has this enzyme that is the alpha-1 antitrypsin that is a self-limiting agent that when it goes in contact with sound dentine or dentine that has the potential to remineralize, it do not remove any longer the dentine. So it has been stated that this strategy is quite conservative in terms of caries tissue removal. We see that these two products has been evolving, and other appeared. One of them was the Biosolve made by 3M in Germany, but unfortunately is not commercially available. It was only during the experimental phase. And the original Papakari produced in 2003 was improved in 2011, called Papakari Duo. That is the one that we have today. More recently, a similar product, Carie Care, was produced, also an enzymatic product, and a couple of years ago, one papain-based product called Brix 3000 was launched to the Latin American market. When we divide the main two groups we have, we will see, of course, advantages and disadvantages. The group from sodium hypochlorite, of course, has the advantage of having more years of research. It has a degradation of hydrogen bridges, bacterial count reduction in many studies. It has complementary uses, such as complementary treatment for root treatments, endo treatments, periodontal care, or some coadjuvant of periodontal care. The disadvantages we have with this component is that it increase the cost of the treatment, increase the time, because it takes from 8 to 10 minutes for the caries tissue removal in comparison of a 2.5 to 3 minutes of use of a burr. It causes some unpleasant taste, smell for the patient, and that's why it's recommended to use absolute isolation. And on the other hand, we have the papain-based components. It has the same disadvantage of increased time and cost. It has shown bacterial reduction to be biocompatible, and has, together with the caries removal effect and disinfection and anti-inflammatory effect. But due to the recent development of this second product, we have limited evidence about the efficacy and safety. When we talk about products, the main representative from the sodium hypochlorite is the Carisol, because the Caridex disappeared from the market. On the papain side, we have the Papakari Duo, actually, and Brix 2000 as the most available products around the globe. In terms of the step-by-step process after a tooth cleaning prophylaxis or a tooth brushing, the sodium hypochlorite of Carisol is applied in the cavity. You have to wait for 30 seconds until the gel is active to start removing the dentine decomposed tissue, and you have to reapply the product until the liquid is completely clear. It's like a signal that you have finished the removal, and always using a blunt instrument with a gentle movement. It doesn't have to be using force to remove whatever you are able to remove, but only doing just like a very mild force with a blunt instrument, and making the gel to do the work. Some studies on microscopy produced by Fernanda Correa show that the efficacy of the product shows some smear layer, some bacteria remains, but most important, some areas that the smear layer was completely removed. So it will be interesting to use it with a self-etch adhesive system after the caries tissue removal. Some studies have shown a significant reduction in the bacteria count. In terms of time, the hand excavation with the ART technique is most time effective, because the use of Carisol will extend the clinical time because of the many applications that you have to do in order to be sure that you are not leaving decomposed dentine. And the use of papain is quite similar to the ART clinical time. The most or the quickest process in this caries selective removal, of course, was the use of rotary instrumentation. And the advantage of this enzyme is to use it as a self-limiting agent because of the alpha-1 antitrypsin produce safety and efficacy in the application of the gel in cleaning the cavities. And just to give you an example of how it works, this is actually a case in the permanent dentition, but could be used in primary teeth, in permanent teeth without any distinction. It's a very patient-friendly approach. In this case, we use absolute isolation due to the fact that it was a case that will be then restored with composite resin, but in pediatric patients could be used under relative isolation conditions without any issue because it's not toxic for the soft tissues. It doesn't produce any smell or taste. But it's just to show you how it degrades the partially decomposed dentine. It could be easily removed with a blunt instrument. And this is only a result with the excavation with the gel. After, you can complement the preparation of the enamel without support or the very brittle enamel with a multilaminate burr, but you can use only hand instrument to do the cavity preparation. In this case, for instance, in the primary dentition. The microscopy shows that it also removes the smear layer, showing some dentine tubules viable after the hand excavation with the enzymatic agent. And some studies have shown that is quite efficient in the removal of selective removal of carious or decomposed dentine. A recent publication have shown the comparison between the most studied enzymatic agent, that was Papacari and Papacari Duo, with this newly produced version of Brix 3000, and they have demonstrated that Brix 2000 takes shorter time with a very comparable efficacy in terms of the noob hardness of the remaining dentine and the efficacy of the selective removal. Something that we have to state is that when we have a well-trained operator or a well-trained clinician in a selective carious tissue removal strategy only with hand excavator, the use of these enzymatic or chemico-mechanical strategies will not add anything to the clinician. It's actually for those who maybe are just recently involved in a caries selective removal strategy. But when we compare hand excavation with mechanical or chemico-mechanical strategy, there are no significant differences. The key element when we do selective removal, being only with hand excavators or in a chemico-mechanical strategy, is to create this halo around the cavity to guarantee the peripheral seal of the restoration. Being glass ionomer or composite resin, we have to guarantee a perfectly sealed restoration to guarantee that the demineralized dentine will be able to remineralize. So the movement that is recommended is this approach to reach that enamel dentine junction and start with the removal in those periphery walls. After doing that, we will then work in the cavity floor, removing selectively depending on how deep the lesion is. Some recent studies on cytotoxicity have shown that it has a mild reaction to cells if it's in close contact. That's why it's important to follow the recommendation of selective carious tissue removal. Not for being a chemico-mechanical strategy, you should reach the hard dentine on the base of the cavity, but respect the principles of caries selective tissue removal. Now, once we are doing our selective removal with a chemico-mechanical strategy, the restoration material will not be a matter of decision-making or decision bias using this type of material, because it works perfectly with glass ionomer or composite resin. This is an example of using chemico-mechanical removal in a medium-sized class 1 cavity using bricks 3000 in this case, and then using a glass ionomer encapsulated cement. First, after we do the cleaning and the caries tissue removal, we wash the cavity with cotton pellet water. We dry it with another cotton pellet, but not over dry the cavity. The cavity should stay mildly moist. And then we apply the polyacrylic acid for the cavity conditioning, wash and dry. And then we inject the glass ionomer into the cavity. In this case, we use this one from the SDI brand. The advantages in general of glass ionomer cements, of course, are the chemical bond. This has a highly biocompatible material. It has the same coefficient of thermal expansion than the dentine, so it's ideal for these particular cavities that keep some enamel completely intact, but have a deeper invasion of the dentine through the dentine enamel junction. It has the property of release fluoride during the first 24 hours, and then it becomes a fluoride reservoir. And of course, in cases of relatively isolation, like the one presented before, glass ionomer cement is more moist tolerant than a composite resin. This is another case using the enzymatic chemico-mechanical removal, but in this opportunity with a primary dentition case, and also restoring with a glass ionomer cement. The chemical product is applied, and we wait for a couple of minutes to start removing, always in the periphery first, trying to get that halo effect or that halo clean of decomposed dentin to guarantee the restoration seal. This is a more patient-friendly procedure than using the burrs, because we don't need a dental anesthesia, because we are only removing dead tissue without any symptoms. It will be more friendly because we are not using that force that we might use when hand excavation only. And in some cases, they not only recommend a blunt hand excavator, but they have like these specially made instruments to remove the dentine after the effect of the enzymatic product. One of the recommendations based on some experiences from abroad are using calibrated excavators to guarantee this 1.5 millimeter seal around the dentine enamel junction. In permanent dentition, 1 millimeter in primary teeth. And this is actually the movement that we should guarantee when using the hand excavation is, sorry for that. To produce this circumferential move around the dentine enamel junction. See? I'm not touching yet the cavity floor. I'm focusing on removing all the periphery of the lesion in order to guarantee my perfect seal of my future restoration. And after I do my cavity cleaning, conditioning with polyacrylic acid. In this case, using a GC product, I am using the cavity conditioner from GC. And after it, I prepare my capsule in this mixture during 10 seconds. The advantage of the capsule is that the proportion of the powder and liquid is perfectly established from the factory, from the manufacturer, and then I can easily inject the material into the cavity with this device. In this particular case, is like I follow the recommendation of the ART with isolation with cotton rolls, and then after applying the glass ionomer, using the press finger technique to guarantee a perfect seal of the glass ionomer in my cavity. If we are not using the encapsulated version, we can use these Centrix tips, because it works exactly the same if we are doing a good mixture of our hand mix version of the glass ionomer, and fill the cavity to guarantee that superficial seal. After it, I will put some Vaseline gel on my fingertip and follow with the finger press or the press finger technique, that is just pushing my finger in top of the glass ionomer and then slide it sideways, not remove the finger vertically, but slide it in the surface to guarantee that I will seal also the pits and fissures around my cavity. In this case, has 3 years follow-up. You might say that there is a dark aspect of the lesion, but actually we are treating sclerotic dentine. Before, we do not remove the dark dentine because we only remove the periphery, and of course there will be a shadow. But if the lesion remains stable, I will not be concerned about the shadow behind the restoration. These kind of approaches guarantee a lower anxiety of the patients, and of course with this lower anxiety, it will be more likely to return to the dental office without fear. And that's something that we have to be very attentive about, because fear is one of the main issues of constant or frequent visits to the dentist. This could be also a very good strategy for this type of cases in young permanent dentition very close to the pulp. Using glass ionomer as well, removing during 2 minutes, using that first access to clean the neighboring teeth, and restoring with glass ionomer cement. Following the same strategy, 2 years follow-up with a perfect seal. Nowadays, this reinforced glass ionomer, that is the Equia Forte, has guaranteed that it will have a higher or a wider recommendations in terms of the cavity size, not only class 1s, but also extensive class 2. And just to finish with glass ionomers, it's a very good option in selective caries tissue removal in cases very close to the pulp. When you see this immediate x-ray, you will say that, oh, you leave some caries beneath the restoration, but it's actually the mineralized dentine. The demineralized tissue will be radiolucid. So if I am trusting in my peripheral seal of my material, for 2 years later, I see that the dentine do his job, remineralize, the pulp move away from the lesion, and of course, I give the chance to that pulp to keep vital. That is the main goal of the glass of the selective caries tissue removal. And the same principles are applied for composite resin. Is cleaning the cavity, the conditioning protocol, and some studies have shown that the use of these chemical-mechanical products will eliminate the smear layer and improve the performance of self-etch adhesives. Of course, using the strategy of selective etching enamel, washing and drying the dentine, and here using the two-step self-etch adhesives for later on using a composite resin. In these times of coronavirus, it's very useful to shorten our procedures and do selective caries tissue removal and follow it by bulk fill technologies. Just one increment. If we have 5 millimeters deep cavities, we can use only one increment to restore this cavity, class 2. And these kind of appliers in a single dose will be in terms of biosafety, are more reliable and are quite effective in adapting to the cavity walls. Independently from the method used, the Burr papain of hypochlorite, sodium hypochlorite, the smear layer will be there very well formed. And today, in times of coronavirus, we should use strategies that do not produce aerosols. We could use selective caries tissue removal, a traumatic restorative treatment, silver diamond fluoride, because you know that aerosols are not only a risk for us, but also for our clinic, for other patients, and for our families. So we should take attention of the recommendation from this publication from Wuhan, in which they are recommending caries tissue removal, even in cases of pulp necrosis, because the caries tissue removal could be also used as a strategy to have an access to the pulp. A traumatic restorative treatment is also a very good strategy in these times of aerosol reduction. And this interesting paper produced by the Latin American Association of Pediatric Dentistry also includes the selective caries tissue removal among other methods to prevent the production of aerosols. So just to finish, dental caries is a behavioral disease. We have to monitor biofilm control and sugar consumption. It could be prevent, stop, or reversed. And the cleaning of a cavitated lesion should be selective always to prevent the exposure of the pulp and promote remineralization. The use of chemical-mechanical method is a safe and effective method, and is more patient-friendly and might improve the addition of our material to the substrate. In this post-pandemic era of dentistry, non-aerosol producing alternatives should be implemented in order to prevent the dispersion of potentially dangerous droplets in our office. Thank you so much for your attention, and I will be here for any question that you may have.
The question is there a particular limitation of carie care?
Thank you for the question. Actually, I am not so familiar with carie care because it doesn't get to Peru. I just only read papers about it. So the limitations are the ones that are present for any selective removal technique with enzymatic methods. My personal experience only goes with Papa Carie and with Brix 3000. So I will be able to speak about those products, but not about carie care. I'm quite sorry about that.
So, Papa Carie, you can highlight something.
Yes, Papa Carie is a fantastic strategy. It has been in the market for the last 15 years, and actually is quite effective and very patient-friendly. It takes a little more time than the traditional removal with a burr, or a carbide burr, or a diamond burr, but in cases of a selective removal with the gel is quite helpful.
Should a child visit a dentist for early prevention of caries?
Fantastic, thank you. Well, actually, we conducted, a group of colleagues conducted a study in the outskirts of Lima regarding the first visit to the dentist. And even though the Ministry of Health promotes the visits as early as 1 year, unfortunately, the patients arrive at the age of 4 for the first consultation, but the recommendations that we are following are the ones presented by the International Association for Pediatric Dentistry. The first visit to the dentist should be with the first teeth appears, or even before, when the pregnant woman goes to the pediatrician. But when we go to the field, it's very likely that they only present to the dental office when they have a problem. So that's quite unfortunate for our country.
Okay. There is another question. What would be the pulpal reaction to Brix 3000 if accidentally comes in contact?
I will repeat.
Yes.
Pulpal reaction to Brix 3000, if any, when accidental contact occurs.
Okay, thank you for that question. Actually, there's a mild difference between the Papa Caries and Brix because in Brix they have like an encapsulated product and also some co-agents that has more biocompatibility with the healthy tissue. So they have shown to have a mild reaction to pulp cells, but it will not produce inflammation response, irreversible inflammation response. In case that it has contact with the pulp, it should be considered, in case of impermanent dentition, a SBEC technique, just removing 3 millimeters of pulp and then trying to use a bioactive cement such as MIT derivatives or a biodentine as an alternative. And in primary teeth, because of the low vascularity, it is clinical recommendation is to proceed, if you accidentally expose the pulp, to go directly to a pulpotomy.
Okay. I think, thank you, Professor Raldo. I think it was really interesting, and I, on behalf of JSS Dental College and the JSS Academy of Higher Education Research, like to thank you for taking out time and being with us. Dr. Chanchala, can you just give a final thanks and to both, also the panelists as well as. We'll be in touch again.
Of course, anytime. I was a pleasure to share this session with you. Thank you so much for the invitation.
Yeah.
Indeed, Dr. Hiraldo. Your expertise is truly valuable. An extensive work and the comparative evaluation that you have provided was very valuable to us. Thank you so much. And Dr. Shivkumar sir, you've been constantly in the webinar. It is so appreciable to see you here with us and your valuable inputs to the webinar as well. Thank you so much, sir.
Nice to be part of JSS anytime. And Dr. Hiraldo, this is the third time I am listening to you. Once on SAAPD, then Saudi Arabian thing, then this is the third one. Every time it is a pleasure. Thank you.
Thank you so much. I hope I didn't bore you with the concepts. Because
We'd like to share the greetings from our Vice Chancellor, sir, as well as the Pro Chancellor, sir, for you having come and joined us.
Thank you so much for the invitation.
Thank you.
Thank you, sir. Bye.
Bye. Bye. Thank you, Dr. Shivkumar. I thank Dr. Shobha Kurikos also for being with us at this meeting.